Up to 38% of patients develop trismus following surgery and radiation therapy for head and neck cancers. An airway challenge arises when these patients require general anesthesia and passage of an endotracheal tube between the teeth is impossible. The option to secure the airway in this scenario is nasal intubation. However, some patients may have contraindications to nasal intubation. Tracheostomy is the last resort, but it is an invasive procedure with serious risks and complications. As an alternative to tracheostomy, we propose using the retromolar space as an entry for flexible fiberoptic oral intubation. In preparation for retromolar intubation, review first the patient's history. Choose the side with fewer erupted molars or the side with molars extracted. This will be the side with more room for intubation. Assess the dimensions of the retromolar space using dental pentomograms and CT scans of the head and neck. Examine the patient and ask him to insert the fifth digit behind the last molar on both sides, choosing the sides with more room. This graphic shows the path of the fibroscope for retromolar intubation. In the retromolar space to the pharyngeal cavity towards the glottic opening and into the trachea. This video will demonstrate the technique for retromolar flexible fiberoptic intubation. In this patient, the procedure is performed after induction of general anesthesia. Ventilation is adequate by bag and mask. An assistant closes the mouth completely to prevent motion of the mandible. A well-lubricated nasopharyngeal airway is inserted to assess the size and orientation of the path. This will also help to create a memory path for insertion of the fibroscope. Arm the fibroscope with a well-lubricated tracheal tube. Insert the scope in the corner of the mouth behind the last molar to the retromolar space. Once in the pharyngeal cavity, follow the curved path between the maxillary and mandibular teeth. Curve the scope slightly to identify the glottic opening. It is a short distance to the glottis, no more than 10 centimeters. The orientation of the fibroscope is different from the midline approach. However, the anatomic structures will appear the same. When the glottic opening is visualized, advance the scope through the vocal cords to the trachea. Advance the tube steadily to enter the trachea using a slight twisting motion if hang-up is encountered. The retromolar approach for flexible fiberoptic intubation has many advantages. It provides an adequate opening for intubation when mouth opening is restricted. It can be performed even in cases of complete mandibular occlusion. The space is always available, sufficiently large, and not influenced by common causes of difficult airway, such as prominent incisors, large tongue, intraoral lesions, and neck range of motion. Even if one side is affected by disease, such as retromolar trigone tumor, the contralateral side may be chosen. The retromolar approach provides a novel option to tracheostomy to secure the airway for patients with trismus.